People who've had a laryngectomy have to adapt to a wide range of changes in life. While in hospital, there's plenty of specialist help on hand. But what happens when they get home? What can they expect from the services in the community? And what do those providing community care need to know? Let's start with the essentials. A laryngectomy operation is usually necessitated by cancer of the larynx. It involves removal of the larynx, often referred to as the voice box. This leads to some major structural changes, and before looking at these, it's worth spending a minute considering the anatomy prior to surgery. Eating, drinking and breathing can all take place through the mouth and pharynx. Food and drink are routed through the esophagus or gullet. Air being breathed in or out travels through the trachea or windpipe.
The larynx is situated at the crossroads of breathing and eating. It's a cunningly developed device which acts to prevent food and drink going down onto your lungs and at the same time allows air to pass at the right time. In doing this, it has a number of mechanisms, the first of which is what's called the epiglottis. It's like a trapdoor at the top of the larynx. When you swallow, the larynx moves upwards, and the epiglottis, being pivoted at the front, flops down like a trapdoor and closes it over and stops food and drink going in.
We all have a voice box, a larynx, which has vocal cords inside. And what happens when we produce voice is that as we breathe out, air passes from the lungs into the trachea and then up into the larynx. And as it enters the larynx, the vocal cords will come together and vibrate as the air passes through them. And it's that vibration of the vocal cords which produces voice.
But following removal of the larynx, new arrangements must be made for breathing, and the surgeon makes a new opening in the neck, a stoma, directly connecting the trachea to the outside world. You may well have encountered other patients who've had an opening made into the trachea as a tracheostomy, an operation undertaken for a whole range of reasons.
The difference between a tracheostomy and a laryngectomy is that a tracheostomy is usually a temporary stoma into the neck, whereas a laryngectomy is a permanent stoma to allow the individual to breathe through. If you occlude the stoma in a tracheostomy patient, if there's no obstruction in the pharynx, you can still breathe through your nose and your mouth, whereas with a laryngectomy, you only breathe through the stoma in the neck.
A tracheostomy always has to be kept open with a tracheostomy tube. The laryngectomy patient doesn't always need a tube in. Some people do and some don't, actually. It very much depends on the individual. One of the things that you need to do is to check with your head and neck unit as to which situation your patient is in, whether they've had a laryngectomy or a tracheostomy.
Mr. Smith?
Yeah.
I'm Leslie.
Oh, hiya, come on in.
As a community nurse, attending to the stoma is likely to be one of your first responsibilities when dealing with a laryngectomy, the name sometimes used for a person who's had a laryngectomy operation.
Dad, I just want to have a check around your stoma, all right, and have a look down your windpipe.
The need for cleanliness is obvious, but more subtle is the need for monitoring the size of the stoma. We want to ensure there's no tendency for the stoma to reduce in size. This demands careful, objective observation because size changes can be quite rapid, but they can also be slow and insidious.
And I want to look down your windpipe as well.
Either way, the consequences can be serious, not just in terms of breathing, but also in limiting access to the valve. The head and neck, or ENT unit, where the patient was treated, will have suggested a method for checking size, and a few possibilities are shown here. Whichever one is used, measurement should be regular, looking carefully for any decrease in size.
Having an airway opening onto the skin directly bypasses the mechanisms which most of the rest of us have, in particular the nose. The nose is an air conditioning device. It filters, warms, humidifies the air. All of these actions are lost if you simply have dry, cold air going straight into the lungs.
It's essential that the laryngectomy patient remains well humidified because this is what enables them to cough up their secretions. If they're not well humidified and their secretions start to get dry and crusty, then it can predispose to chest infections. You can also have larger pieces of crust which can actually block off the stoma.
Normally, the nose filters, warms and moistens the incoming air. By not breathing through the nose, a laryngectomy misses out on these important benefits. This can lead to complications, including chest infections.
There are a variety of devices available to compensate for the lost benefits of breathing through the nose and the mouth. One of these is the heat-moisture exchange system.
An HME consists of 3 parts. A base plate that sticks against the patient's skin around the stoma, an adapter and a cartridge. This allows the air that the patient breathes in to be warmed, humidified and filtered.
Some systems are available on prescription and some have to be paid for, so patient preference is a factor. Additionally, each head and neck unit has its own ideas on which is best. Well, this means there'll be differing views around the country as well as changing views over time. All we can do here is give you a general introduction. To help on issues like this, it's a good idea to establish a rapport with your local head and neck unit, ideally before the patient is discharged into your care.
Hello, could you put me through the head and neck unit, please?
HMEs all work on the same principle. By trapping heat and moisture from the air being breathed out, they can reapply that moisture to the air being breathed in.
That filter behaves like your nose. If you think of your nose with the hairs in it, it actually warms the air. It gives it a little bit more moisture, and that's exactly what I've got with this filter. At the end of each day, or in fact in the morning, I change it.
It's quite sticky, but we've got to make sure that
The heat moisture exchanger needs to be changed regularly. Usually that's at least every 24 hours. The adhesive that's applied to the skin normally needs to be changed about every 48 hours.
Right, we've got to make sure that the base plate has a good seal all the way around, because if air escapes then it won't work properly. So do you mind just having a little go and see what that feels like?
Yeah, that feels fine.
Good, good.
In addition to that, you can encourage your patient to take breaks from wearing the HME system. In fact, this is very important to maintain integrity of the skin.
The patient who's experiencing difficulty applying the base plate should ensure that their skin is kept clean and dry. If, however, the base plate still won't stick, they can use a special skin adhesive glue.
For those who can't tolerate the adhesives that are used with the system, you can attach the heat moisture exchanger directly to a laryngectomy tube or a stoma button.
There are special considerations for anyone undergoing radiotherapy. They can use a tube or a button, but not a base plate, since the adhesives would exacerbate the skin problems associated with radiotherapy. Another approach is to use protectors, including various forms of clothing, such as neckerchiefs, scarves and covers like cravats. These all provide a degree of filtration, and the purpose-made ones act like HMEs, helping to moisten the air being breathed in. In terms of body image, they're a big help, but they must not restrict breathing. Once again, the message is be familiar with your patient's own system and check the head and neck unit is happy with its use.
In the initial stages, I think the actual clearing of the throat, etc., was time-consuming, in as much as the mucus before it healed was probably every 2 to 3 hours, whereas now today, I'm just normal coughing.
There is a much greater awareness of phlegm after laryngectomy because the patient is coughing the phlegm out through their stoma in their neck and it becomes much more obvious. Almost all patients learn new techniques for doing this because this starts actually very early in the post-operative period. And by the time they go home, they're competent at clearing their airway through the stoma. A few patients, however, don't manage this entirely and do need to go home with suction apparatus. Normally, they would only go home with this when they're competent at using it. If you have any queries at all about suction equipment and the use of suction equipment, then you're best to contact your local head and neck unit. Of course, it's always much easier to expectorate thin secretions, and keeping well hydrated has got an important part to play in keeping secretions thin and easy to expectorate.
Having a stoma does leave individuals who've had a laryngectomy more open to infection, and it is very important that they learn at an early stage how to spot these signs of infection so they can be dealt with early rather than grumble on and cause later problems.
It is important the individual recognises changes in the amount of phlegm being produced, consistency of same such as thickening, and also discoloration of phlegm. It is also important that they monitor their own breathing rate in regard to seeking help if they feel that there are any changes.
Ivor, it's really important that when you're checking your stoma, you check for signs of infection. So you would have a look around the site and also inside, and then you would look to see if there was any redness or inflammation or any discharge. You might find that you have an infection if your phlegm's a different colour or if there's any itch.
The stoma area can become infected too, and it's necessary that they are aware of any changes in the skin which would indicate inflammation or infection. That includes any redness, swelling, pain or discomfort in that area.
If crusts are allowed to build up, not only do they become locally inflamed and can get infected, but importantly, if they are to cough up a small further bit of crust, it can block off the stoma completely, albeit briefly, and this may necessitate emergency admission to hospital.
Day-to-day cleanliness has added importance. Most laryngectomies become adept at this, but the community nurse can provide helpful support. The essential requirements are really clean water, bright light, mirror, and clean forceps to remove crusting or particles. Initially, they'll need swabs, but later they can use a flannel reserved for this purpose. Cleaning around the edges can make patients a little uneasy at first, but with your help, they'll quickly become more relaxed. Careful use of the tweezers is an important skill for anyone who's had a laryngectomy. Most people take a little while to gain competence and the confidence that goes with it.
Well done.
The nurse can do a lot initially by having the patient watch what she's doing and learning from her, and then observing the patient, giving them support as they're doing it themselves.
An important item that needs to be kept clean is the valve used in the prosthesis method of voice restoration. We'll be looking at how this works in a moment, but first let's concentrate on its care.
The inner valve does need regular cleaning. It needs regular cleaning with a brush. There's a special brush provided, and initially this needs to be done 2 or 3 times a day. So the patient will look to you for help at the beginning. However, most people like to be independent and very soon are able to move on to managing to do this themselves.
If somebody is having problems with their voice and they're not able to produce voice, the first thing would be to check that the valve hasn't blocked.
In regard to cleaning the valve prosthesis in situ, this can be done either using a brush or a pipette. In order to use a brush, the brush is gently inserted into the valve prosthesis and gently rotated on removal. In regard to the pipette, this is filled with normal saline or with distilled water and flushed gently.
It might make you a bit cough, but I'll need to remove it.
As well as cleaning inside the valve using the brush, the nurse may notice some secretions adhering to the valve on the outer surface. This can be cleaned by using forceps and gently removing the crusts from the valve.
If the patient has experienced loss of voice, the valve should be cleaned. If there is still no voice, there is a clear need for referral to the head and neck unit.
Leakage is a potential problem with the valve. There's 2 types of leakage. You can either have leakage through the valve, in which case cleaning with the brush may solve the problem. If there is leakage from around the valve, you should ask the patient to stop eating and drinking and arrange for the patient to go back to the head and neck unit to be seen by one of the specialists there.
One of the fairly common problems in the early days of the valve prosthesis is that the tissue where the prosthesis lies, commonly known as the party wall, decreases in size, which then makes the valve prosthesis slightly too long. This can be evident by the actual prosthesis itself having a form of pistoning movement from the esophagus into the trachea. This becomes very problematic in that fluid can collect at the esophageal side and actually leak around the valve into the trachea, and therefore causing some aspiration.
If the valve must be removed for any length of time, a catheter may be inserted into the fistula to prevent it from closing.
There are some types of valves which are called X-dwelling valves, and these are valves that can be removed and replaced by patients. And if patients can manage to do this themselves, it's obviously quite a big advantage to them, because it will mean that they don't have to return to their centre to have the valve replaced.